Good evening, panelists. Good evening, attendees. We would like to welcome everyone to our course for tonight, which will be given by Dr. Muhammad Mekdadi, Cow's Milk Protein Allergy, made it easy. On behalf of TATKIF, we would like to thank you and acknowledge On behalf of TATKIF Health Treatment Undertaking Services, we would like to take this opportunity to acknowledge the presence of Abbott Laboratories SA, who is our sponsor for tonight's session. Dr. Muhammad Mekdadi will be introducing himself further to us. We would just like to inform everyone of our short important notes. At the end of today's session, after processing all the attendees' time in, we will be sending in an email two links. One is for the evaluation and the other one is for the post-test. Once everyone have filled it out, it will notify our admin and we will sending you your CME certificate for tonight, which is accredited by Department of Health with 1.5 CME hours. Also, we would like to request everyone, panelists and attendees, to keep their microphone off and also their video to avoid any distractions with our speakers' sessions for tonight. Once again, we would like to welcome you and we hope you'll have a wonderful, grateful, and interactive sessions for tonight. Dr. Muhammad, you can share your screen and you can start unmuting your mic.
All right. Good evening, everybody, and welcome to tonight's event. I'd like first to thank Ms. Kim from TATKIF for giving me this opportunity to be with you tonight here, and thanks for Abbott Nutrition for sponsoring tonight's event. Well, I know you have been invited to so many different webinars recently, and I hope today will be one of these helpful ones that will you remember for a good time after that. Tonight, I'd like to talk to you about cow's milk protein allergy and how to make it easy and straightforward to the practicing physician or dietitian or a nurse. Throughout my talk, I put some questions that I think Ms. Kim have shared it with you earlier. And these questions are not, of course, to test you, because I'm sure you know it all, but actually to remind us of the important points that we have to keep in mind, and to the points that probably you have been asked by the parents and probably will be continued to ask by the parents about that. When I checked, I found that there is more than probably 270 attendees, and TATKIF has informed me that probably you're coming from different GCC and Middle Eastern countries, and I will be very happy to hear back from you your feedback or comments or the questions. I don't have access to the chat during the presentation, but you can put questions there and I will be happy to look at it after. I hope my voice is clear as well as the slides. All right. Many of you, I looked through the names, I know you personally. For the people who I have not had the chance to meet, my name is Muhammad Mekdadi. I'm a pediatric gastroenterologist. I'm practicing here at Sheikh Khalifa Medical City in Abu Dhabi, United Arab Emirates. So tonight I have 5 learning objectives. We'll have a quick introduction, a background, things to keep in mind about cow's milk protein allergy. Then we'll touch a little bit about the role of bioactive substances and the HMOs, the human milk oligosaccharides. We'll talk about clinical manifestation, variable manifestations, and I'm not going to mention all of them. I'm going to focus on the commonest, the ones you will see in your practice, and then we'll touch a little bit about how can we prevent cow's milk protein allergy and other kinds of allergies, and then we'll talk briefly about the management as well. Hopefully we'll cover these 5 points within the coming 30 minutes. The background, I think we all agree that cow's milk protein allergy is common. I put for you here that often is not properly diagnosed. I'm sure in your practice you have seen an over and under diagnosis of cow's milk protein allergy. And over diagnosing or under diagnosing is probably not a good thing, as the patients might suffer if they are not diagnosed well or put on a restricted diet unnecessarily when it might not be needed. Why it's over or under? Because currently we don't have a specific, objective, reliable diagnostic tests. All the tests we have are with a lot of false positives and false negatives. The only good test is elimination rechallenge test, i.e., a patient comes with symptoms, you eliminate the cow's milk protein in their diet, the symptoms disappear, you reintroduce the protein, the symptoms appear. That's the best diagnostic way. Although this is sometimes is difficult, but probably that's the best way to be 100% sure of that and try to avoid delaying the diagnosis, prolonging the symptoms, or unnecessary diet restriction. All right, what is the strongest influencer? It's probably your genetics. Let me share with you this graph, and I'm sure you have seen probably a various format of this graph. At the top, as you can see, if none of the parents are atopic, the father, the mother, they don't have allergy, the risk of allergy is still there. It's about reaching up to 15%. If one of the parents have some allergic or atopic manifestations, the risk will jump up to even 40%. And similar number if one of the older siblings have allergies. If both parents are allergic, the father is allergic and the mother is having some allergies, the risk even exceeds 50%, i.e. up to 60%. But if both of them, they have the same allergies, then the risk can reach up to 80%. So you're almost sure that. So you can see very clearly in this graph, the risk increases once some or more than one person in the family is having allergy. Please keep in mind that this number, that even in the absence of history of allergy in the father or the mother or the siblings, still some of the children will develop allergies because some of the genes, they have got it remotely in their system. So what's the take-home message from this slide? Obviously, you cannot change your genes. It's a bit too late to change your genes. But I would suggest before, if you are still single, looking for a spouse, ask him or ask her, do you or anybody in your family have eczema or asthma or allergic rhinitis or food allergy? Because if he or she answers yes, your offspring may have an increased risk of allergy. Of course, this is a joke. It's too late for most of us here if you are already married to somebody with allergies. All right, let's talk about the allergic march. Let me spend a minute in this important diagram. In the x-axis, as you can see, is the age in years from 0 to 15. In the y-axis is the prevalence of certain kind of allergies. Please note that early in life, the gastrointestinal in brown here is the commonest manifestation. This is why we are talking today. Also early in life, the skin manifestation, the eczema manifestations are the commonest early in life. As you grow up and as you can see in this curve, with age, your risk of GI and your manifestations of GI and skin manifestations start to decrease. At the same time, unfortunately, your risk of rhinitis and asthma, upper or lower respiratory tract allergic manifestations start to increase. So this is the same child who have early manifestations in life, he will improve, and once he gets older, he will have this. So when I see a patient with cow's milk protein allergy at the age of, let's say, 4 months, I will tell them, most likely he will outgrow his allergies, but I bet you when he becomes a teenager boy or girl at the age of 10 or 15, he is more likely to have allergic rhinitis or asthma. At the same point, the other way around, when you see a teenager with asthma, I will ask the mom, when he was younger, did he have eczema? Did he have some GI manifestations? And probably the answer is yes. All right, so that's a good piece of information. But what I learned from this allergic march is something that's very, very important, which is the window of opportunity, the intervention. If we can prevent cow's milk protein allergy in a young infant today, hopefully in 10 years from now, we can reduce the risk of having allergic rhinitis or asthma. So there is a window of opportunity. There is a bright light at the end of the tunnel if we can prevent the allergies today in the young infants. All right, let's talk about the bioactive substances and the human milk oligosaccharides, which seems to be everybody's talking about that these days. I think we all in the audience, physicians, dietitians, and nurses, and other healthcare workers, we agree that breastfed babies are at lower risk of having allergy. And part of this is the unique protein composition and also the bioactive substances that are present in the breast milk. Currently, there's probably hundreds of different bioactive substances that might affect the allergy and the immune response and the Th1, Th2 balance. Bioactive substances have been there. Now we are discovering and learning more about it. Some of it are the prebiotics, some of it are the postbiotics, and there is other enzymes and there is other chemical materials there that's so important. Of course, these bioactive substances, they don't have any nutritional value, but their value is actually beyond nutrition. The human milk is very interesting by having what's called the human milk oligosaccharides, which is so unique to the human milk. Actually, it's very abundant in the human milk. It's probably the third largest component there, and it's almost absent in the cow's milk. Traditionally, the formulas, or the formulae rather, did not have any human milk oligosaccharides, although recently over the last decade or so, there is a more interest in that, and we'll discuss how to add it to the infant formula and how to make it beneficial to the growing infant. HMOs, or human milk oligosaccharides, are actually more than what you can imagine. There is at least 200, and I bet you probably there is much more. As we discover more, we'll find more and more of these human milk oligosaccharides. These 200-300 or more human milk oligosaccharides, they function probably differently. Each HMO probably has a different function. Probably they work in synergy, or they help each other to have a complex change. You don't want them just to be an immune enhancer or immune suppressor. You want them to be a balance between these. What's more interesting is that the HMO composition is different among ladies, i.e. a lady who's lactating in the United Arab Emirates, probably she has a different HMO than a lactating lady in Japan or in China or whatever she is. And this probably HMO composition is variable, i.e. in the first week of lactation, the HMO composition is probably different than at the age of 3 or 4 months of lactation. As I mentioned, the cow's milk does not have any HMOs. Currently, a couple of these are being able to be manufactured in the lab and added. The commonest and the most studied HMOs are the 2FL and LNNT. These are probably the most abundant and the most studied, and they actually are can be manufactured in the lab. And many of the infant formula companies, they have adding it to the infant formula for obvious benefits. Kim, can we have the first question, please? All right, so which of the following is a GI manifestation of cow's milk protein allergy? Let me see. It's the blood with stool. Is it hematemesis? Is it jaundice? Is it overweight? I will give you guys a few seconds to answer this. Kim, are we going to get the answers now, or we'll get it at the end?
I'll be releasing the results now.
Okay. All right. So most of us have said blood in the stool is probably a manifestation. Hematemesis is possible, but that's much less likely. Jaundice is probably not. Overweight typically is not. Thank you, Kim. All right. All right. Let's go to the next slide. And I think, Kim, you have to give me the power to change.
Can you please try?
I'm trying. Yeah, all right. Yeah, you're right. This is a graph or a diagram rather of the different HMOs in the breast milk. As you can see, there is many structures. I have highlighted for you the 2FL and the LNNT. These are the commonest, the most abundant, and the most studied, and maybe one of the important ones as well. All right. Um, and this is why all this focus in the 2FL. I have a cat here and it's annoying me. All right. The 2FL in the infant formula have been fairly studied. It was found to be well tolerated by the infant when they add it to the infant formula, and it's working there, and it's absorbed there and excreted in the very similar way to the human milk. So safety, we are fairly sure it's safe, and we are fairly sure it might add to the benefits of the 2FL, to the infant health. Slides are slow. Let me see one. All right. All right. Moving on to the clinical manifestations of allergies. My slides are not moving. All right. Here is the Middle East statement of prevention and treatment of cow's milk protein allergy that I happen to be one of the co-authors of this publication. It was published in 2014. I think it's still valid to date. I'll be happy to share a copy of this. In this, we were a group of practicing pediatricians and gastroenterologists from different countries in the region, and we looked at all the literature and we came up with the Middle East consensus statement about that. I will share some of the simple graphs that we published in that paper. And my slides are not moving. I think I should push like ahead of time, so because it takes time to. All right. This is one of the tables in our paper where we summarized different manifestations of allergies. We spoke about the systemic manifestations, then we'll talk about the GI manifestations, then we'll talk about the skin and dermatological manifestations and the respiratory. I will take them one by one and we'll discuss it in more detail. In the systemic manifestations, if this computer will help me, is usually the anaphylactic reaction, and usually this happens within a couple of hours of the ingestion. Typically, the patient is very sick and they present with anaphylactic reaction with hypotension, tachycardia, poor circulation, cyanosis, followed by respiratory manifestations like stridor and other symptoms as well. One of the other systemic manifestations, the F5, the food protein induced enterocolitis syndrome. This usually happens at the age of 2-3 months. Usually it's induced by rice, sometimes by cow's milk. They come with severe vomiting, severe diarrhea, and respiratory, circulatory shock. This IgE mediated is serious and needs to be treated immediately. And again, it can happen between a couple of minutes to a couple of hours after the ingestion. The GI manifestation was probably the second or the most common, I would say. It can be very variable. It includes all these symptoms I have listed in this table, but the commonest of all is blood in the stool. Again, it can be vomiting, can be dysphagia, it can be delayed gastric emptying, abdominal pain, even constipation, failure to thrive, and the eosinophilic disorders as well. From the GI, I have picked for you the enterocolitis because I believe the enterocolitis is the commonest of all. The typical story is a baby who has been fed an infant formula for a while or so. Typically, they are a healthy looking child. Usually, it takes a couple of months for the symptoms to appear, and that's sometimes confusing because the mother will tell you, I have been using this same formula since he was born. Why the allergy appears today? It takes time for the allergy to develop. Typically, it's a tinge of blood or streaks of blood with the stool. Typically, there's no diarrhea, but the stool can be softer, but typically it's not a watery diarrhea that we see. Typically, the child is fussy and crying, and sometimes you might see a little bit of mucus in the stool as well. Well, as you know, now in the digital world and the WhatsApp, if you open any pediatrician's mobile, you will see pictures like this. This is from my mobile. This is a child with what appears to be some blood in the stool in his diaper. This is a typical manifestation of cow's milk protein allergy. Of course, this is not the only manifestation. There are several causes of blood in the stool, but cow's milk protein allergy is probably the commonest in an otherwise healthy child who does not have diarrhea. If you end up scoping these children, this is a normal colon when we biopsy it, and this is an eosinophilic colitis. This is a colon of a baby who has allergic colitis, and all these pink dots here, they are eosinophils. So these are the hallmark of the disease is eosinophilic colitis. Sometimes you might see a bunch of them, and they might even call it eosinophilic abscess because there's too much of here in this table, I put for you the difference between milk allergy and lactose intolerance. Because many parents, they come to you and they tell you, oh, me, I'm the mother or the father, I have a milk problem. But actually they don't, probably they have a lactose problem. Let me run through some of the differences. The milk allergy is an immune reaction to protein, while the lactose intolerance is probably a different thing. It's a carbohydrate malabsorption, inability to digest the carbohydrate. Milk allergy typically appears early in life, as we said, in the first couple of months of life or so, while lactose intolerance usually happens later in life. Typical age is a school age child. Very unlikely to see a lactose problem in the first months of life. Milk allergy, typically they have GI and other manifestations like dermatological manifestations or respiratory manifestations and others, although but the lactose is probably a GI problem, only abdominal distension, diarrhea and gases and so on and so forth. Milk allergy can cause failure to thrive. Lactose intolerance can cause, although it's less likely unless they are consuming a huge amount of dairy products. Milk allergy can be life-threatening with the anaphylactic ones, while lactose intolerance is probably cannot be a life-threatening. Typically, it's just some troublesome symptoms. Dermatological manifestations, sometimes we see a florid manifestations like angioedema, eczema, urticaria. Sometimes it's manifested as only dry skin or itching like this. It's not rare at all. About 1/3 of the children, they present with eczema and eczema-like symptoms. And the beauty of it, once you treat them with an extensively hydrolyzed formula, all this eczema and the dry skin and these manifestations, they improve. Respiratory manifestations are not rare either, a little bit less than the skin manifestations. They can vary from upper respiratory, like allergic rhinitis, or it can be a stridor, or it can be a lower, like wheezes or chronic cough. One of the questions I get from our dear colleagues is how to differentiate between allergic respiratory manifestation versus infections, which is fairly common. A few things that might help you. If a respiratory symptom happens outside of the season, we know that respiratory illnesses are typically winter symptoms. If they happen in the summer, this is typically, or this could be allergic. or if it takes too long. We know an average respiratory illness will take few days, and by the end of the first week, it should start improving significantly or disappear. If it lasts, if the mother tells you this child has been coughing for 2 months, then that's probably an allergic manifestation. Or if it does not respond to the typical treatment, this is suggestive of allergy. Okay, we talked about this. And again, these patients they will respond to hydrolyzed form. I have another group of patients that I don't think it has been described in the literature. And sometimes you see these children who don't have a florid manifestations of allergy. Typically, they have early reactive airway disease or wheezes. They have dry skin, but it's not like real eczema. Their growth, they are not failing to thrive, but they are difficult to put on weight. And typically, the mothers are very nagging. I'm sorry to say it, but these typically they have been shopping from one physician to another physician. Nothing seems to help this child. He gets sick very frequently, and he does not sleep well. His life is not happy at all. I'd like to call these people, sometimes I call them the nagging mother syndrome. Indeed, if you see a patient like this, I think it's worth trying. Eliminate the cow's milk from their diet, see them back in a couple of weeks from that, and see if their symptoms improve. If they improve, this is suggestive of allergies. Moving on in the last few minutes to talk about prevention and then the management. Prevention, I think we all agreed that the best way to prevent allergy is by exclusive breastfeeding for the first 4 to 6 months. And after 4 to 6 months, introduce the solids without any restriction. If the infant is not being breastfed, then probably your second best is to use a partially hydrolyzed formula, i.e. known as HA formulas, hypoallergenic formulas, and this is probably the best way to decrease the risk of allergy. Breastfeeding, exclusive breastfeeding, and if not, to consider partially hydrolyzed formula. During pregnancy and lactation, please do not restrict the mother's diet. She should eat everything to that. The reason behind that, when the mother, for example, eats oranges, some of the antigens of the oranges will go through the breast milk, and they will stimulate the child to be tolerant to the oranges, for example. No need for any restriction for prevention at all, neither during pregnancy, neither during lactation, unless the child has symptoms of it. All right, management, I will summarize it for you in a couple of graphs. Again, this is from the Middle Eastern guideline. If the child is breastfeeding, your life is good. Please continue breastfeeding. Do not stop breastfeeding, but tell the mom to avoid all kinds of dairy products in her diet. Dairy products means milk, cheese, yogurt, lebani, whatever, all these things they should be accepted. Obviously, the mom has to take some calcium supplements during that. Unfortunately, sometimes I see mothers were advised not to breastfeed because of allergy, and that's probably the wrong advice. They should continue to breastfeed and breastfeed well, but avoid any dairy and dairy products. Here we summarized in our paper if the child is not being breastfed. If he's not breastfed and there was an anaphylactic reaction, please use amino acid formula till the age of 1 year, period. That's very straightforward because you cannot afford any mistakes in anaphylactic reaction. If it's not anaphylactic reaction, if it's a GI manifestation, skin manifestation, or a respiratory manifestation, then the best treatment, if he's not being breastfed, is to give extensively hydrolyzed form. If the extensively, you give them the extensively hydrolyzed formula and you said, let me see you back in 4 weeks. If after 4 weeks they improved, then you continue extensively hydrolyzed formula for a year. If after 4 weeks the symptoms did not improve, then you have two possibilities. The first possibility, your diagnosis is wrong. This is not allergy. Okay, so you have to think about the history of the physical exam. Or this is a severe allergy that would not respond to an extensively hydrolyzed formula. They will need an amino acid formula. If that's the case, you put them in an amino acid formula and you said come back in 4 weeks. After 4 weeks, either they respond or not. If they respond, then this was a severe cow's milk protein allergy, and you continue amino acid formula till the age of 1 year. If they don't respond to an amino acid formula, then this is not allergy, because 100% of the allergic children should respond to an amino acid formula. If they don't respond to an amino acid formula, then this is not allergy. Your diagnosis is not correct. You have to rethink and reanalyze the symptoms and the signs of this child. So let's recap this. Exclusive breastfeeding, continue breastfeeding, avoid dairy products. Not breastfeeding. If it's anaphylactic reaction, start amino acid formula till the age of 1 year. If it's not anaphylactic reaction, then extensively hydrolyzed formula and recheck them in 4 weeks. If they don't respond, consider amino acid formula, and you continue all this till the age of 1 year. By the end of the first year, most of the infants have outgrown their allergies, although some of them they might continue till the age of 2, 3, 4, 5, 6, or even more after that. All right. Extensively hydrolyzed formula, 90% they will respond, typically within a couple of weeks of using the extensively hydrolyzed formula. When to use an amino acid formula from the beginning, as I said, in the anaphylactic reaction, in the shock-like presentation, it can be used at the first line if the child has severe allergy. For example, a child with hypoalbuminemia or faltering of cough. If the child is failing to thrive or the albumin is low, this tells me this is severe allergic reaction. These patients, I will start them in an amino acid formula if they are not breastfed infants. So, ladies and gentlemen, over the last 30 minutes, I discussed with you that the best way to prevent and to treat cow's milk protein allergy is by exclusive breastfeeding. I mentioned to you briefly about the bioactive substances. We focused more on the prebiotics and human milk oligosaccharides and their potential role in improving the symptoms and the allergic manifestations of children. We focused more in the 2FL and LNT as being the major components and the most studied HMOs there. We talked about the use of therapeutic formulas if they are not exclusively breastfeeding, like an extensively hydrolyzed, which should work in 90% of the infants, or amino acid formula, which should work in 100% of the infants of allergy. Again and again, if you give amino acid formula for somebody and the symptoms do not improve, he does not have allergy, this is something else. I think with this, I will hand the floor back to Ms. Kim, and I think there is a second speaker from Abbott, and we'll be happy to have any questions or answers entertained after the second presentation.
Thank you so much, Dr. Mohammed. That is a very interesting topic. Without further ado, we would like to welcome Ms. Dilek from Abbott. Ms. Dilek will be giving us a short introduction or a short presentation of the current Abbott product. Ms. Dilek is the Area Marketing Manager of Adult and Pediatric Medical Nutrition in Abbott Laboratories. Ms. Dilek, you can unmute your mic and also share your screen.
Good evening, everyone. In a minute, I will be sharing my screen. Can you see my screen, Kim?
Yes, Ms. Dilek, we can see your screen.
Yes, okay, perfect. Thank you very much. I will thank you, Dr. Mekdadi, for the wonderful presentation. I will just take a couple of your minutes to talk about our recent launch in UAE and also in the Middle East. And then I will play a very short video. I hope you will enjoy it, and then we will continue with your questions to Dr. Mekdadi. So just to give a very small brief about the certain challenges that these allergic babies are experiencing. When breastfeeding is not possible at certain times, hypoallergenic formulas can help these babies that may develop experiencing the allergic symptoms. So of course, when the first line, as Dr. Mekdadi mentioned, the first line recommendation is usually breastfeeding, with especially the benefits of the supporting nutrients, also as well supporting the immune system of the developing infants. However, when it's not possible, hypoallergenic formulas are recommended to help to relieve the symptoms as well as to help the growth of these babies. So the first years of life is critical for the babies. For the first years of life is very critical for the immune development of the babies. And as well, it is mentioned, HMOs are uniquely important as they play a key immune modulator for the developing babies. They are the most abundant, the third most abundant component in the breast milk. And some of well-known functions of HMOs are said as supporting the gut microbiota development, helping the gut barrier maturation, providing antipathogenic effect, and helping immune modulation. So some known vulnerabilities of formula-fed infants, when compared to exclusively breastfed infants, they are experiencing more infections, 50% of the time experiencing more eczema, more atopy. When compared again the serum inflammatory marker levels, it's seen that TNF-alpha and interleukin-2 is seen elevated in the formula-fed infants, and also allergic manifestations are seen more than exclusively breastfed infants. So as Abbott Nutrition, we are very happy to announce, I'm sure most of you already heard from our teams, despite the challenges today to see you face to face, unfortunately. But Allergy has been in the market for a while, and now it is we are very happy to introduce Allergy with 2FL HMO, very short after our launch in UK, Netherlands, and in multiple European countries. Allergy HMO helps to support the immune system of the developing infants. It supports the healthy growth and as well symptom resolution as expected from any amino acid formula. And it is also in studies, in consumption studies done in UK, in the US, confirmed as a trusted brand by mothers and also by healthcare professionals. So HMO, as Dr. Mekdadi mentioned, it's not new. It's been researched for the last 2 decades, maybe. It's put more recently in the infant formulas, and now we are talking about bringing it to an amino acid formula to help allergically immune compromised babies. So in healthy term infants, to show the effect of HMOs, 2FL HMO when compared to standard formula, which it helps to reduce respiratory infections by parenteral reports. It helps to reduce the inflammatory cytokines when compared to, especially in the levels of the breastfed infants. And also it helps to reduce the reports of eczema. So looking at in a very short snapshot, Allergy without HMO has been in use for our healthcare professionals for a very long time. It's in the market for more than 20 years. It is a hypoallergenic formula that supports the healthy growth of infants with cow's milk allergies, severe multiple food allergies. 9 out of 10 parents reported that it helps to resolve their baby's symptoms, and it is well tolerated. And also it is on top of maybe allergic reasons, it's also shown to improve gastrointestinal disorders like malabsorption, short bowel syndrome, and chronic diarrhea. So what I'll do is I'll stop here and I will share a short video with you.
Ms. Dilik, sorry to cut, but the video doesn't have a clear sound. Can you try to view the options of Zoom? There is an option to share computer sound.
Where exactly?
If you touch the 3 ellipses button, which is more, you can see an option to share computer sound.
Yes.
Allergy in the first year of life. In addition to providing nourishment for growth, breast milk creates an important foundation for immunity, such as helping to develop the gut microbiota and modulating systemic immune and inflammatory responses. This is provided by key immunomodulators such as human milk oligosaccharides, or HMOs, the third most abundant solid component in breast milk. 2-fucosilactose, 2-FL, HMO, a trisaccharide consisting of glucose, galactose, and fucose, is the most abundant HMO in most mother's milk. Around 80% of women can produce and secrete 2-FL HMO in their breast milk, which has proven benefits on the gut and systemic immune responses. Prebiotic sugars, such as galacto-oligosaccharides, GOS, and fructo-oligosaccharides, FOS, are less complex compounds than HMOs. Like the HMOs found in breast milk, they are capable of promoting microbiota growth and maintaining epithelial gut barrier integrity. However, GOS and FOS do not appear to have a direct role in helping support the systemic immune system. But how does 2-FL HMO work? 2-FL HMO is a non-digestible carbohydrate, which, after passing through the infant's body, reaches the colon, where it promotes a number of benefits there and beyond. 2-FL HMO shapes the intestinal microbiome by serving as a substrate for beneficial bacteria like bifidobacteria and lactobacilli. Bacteria like bifidobacteria metabolize 2-FL HMO into short-chain fatty acids, which creates an acidic gut environment that inhibits pathogen growth. The short-chain fatty acids derived from 2-FL HMO also have important benefits on the intestinal epithelium, stimulating mucin release and tight junction development. These act as physical barriers to prevent pathogens and allergens from entering the systemic circulation. 2-FL HMO has also been shown to increase the expression of toll-like receptors on intestinal epithelial cells, enabling the gut to recognize pathogens and mount an immune response against them. 2-FL HMO can minimize the binding of pathogens to intestinal epithelium by acting as receptor decoys and thereby prevent pathogens entering the blood. HMOs resemble some of the glycan structures found on the receptors of epithelial cells, so any pathogens that recognize and bind to 2-FL HMO will pass down the intestinal tract and out of the body. Many studies suggest that 2-FL HMO also directly modulates immune responses, both locally in the gut and at the systemic level. In vitro studies have shown that 2-FL HMO downregulates inflammatory cytokine expression in intestinal epithelial cells. Unlike other prebiotics, a small amount of 2-FL HMO crosses the epithelial gut barrier and is absorbed into circulation. Consequently, 2-FL HMO can exert systemic immune effects. Clinical studies have shown that 2-FL HMO can enhance the development of the systemic immune response. Healthy preterm infants fed formula with 2FL HMO were shown to have significantly fewer parent reports of respiratory infections compared to infants fed formula without 2FL HMO. These infants also had significantly lower levels of multiple inflammatory cytokines and significantly fewer parent reports of eczema. With the launch of hypoallergenic formulas with 2FL HMO, you can provide mum with everything she would expect from a formula, while supporting her infant's immune development in the gut and beyond.
Thank you very much. I think, Kim, it's back to you again.
Thank you very much, Ms. Dilick, for that wonderful presentation. I think some of our attendees are interested with it, and they would like to have a copy of the presentation you have provided.
Yeah, of course.
Okay. For the meantime, to address the Q&A, I'll be muting your microphone and closing your video. We are happy to have you until the end of today's session. All right, Dr. Mohammed, we would like to go back with your session. Before we address the question and answer or questions from our delegates, we would like to post some of the poll questions just to see the responses from our attendees.
Okay, well, I had to skip some of the questions because of the interest of time, and I don't want to be too late for Ms. Dilick's presentation. So yes, let's post them now.
Thank you.
All right, you want me to read them loud? I can. What is the typical age of presentation for non-IgE cow's milk protein allergy? Let's see the answers. All right, so most of us have said 2 months. That's very true. For the non-IgE, it's typically after the 2nd month of life. Of course, it can be earlier, but that's the atypical. And typically by the end of the 1st year, they outgrow it. So the correct answer would be 2 months, which is B. Okay, let's do the next question, Ms. Kim. Is cow's milk protein allergy more common in formula-fed infants? I think, all right, let's see what the audience would say. Absolutely. So it's very true. Allergy is much more common in the formula-fed baby, up to 5%, and the breastfed baby it could be 0.5 to 1%. Yes. All right, excellent. Can we pose the next question, Ms. Kim? Parents with allergies are more likely to have children with allergies. I gave you my marriage advice or pre-marital advice. Can we have the answers, Ms. Kim? All right, so 94% they said yes, and that's probably very true. If you are single, you still have time to run away. All right, let's pose the next question. Does cow milk contain HMOs? I think that's a question that was answered by myself as well as by Ms. Dilick. I'm trying to say your last name, Ms. Dilick, but I would not even dare to try. It sounds a difficult last name. All right, so 70% the correct answer. Cow's milk does not have HMOs. It's called a human for a good reason. And as Ms. Dilick have explained to us, now infant formula, they are have the advantage of having some of the HMOs added, like the 2FL, even in their amino acid formula, they have added that. All right, doing very good. Which one is true regarding skin manifestation of cow's milk protein allergy? It is a rare manifestation, usually responds to topical steroids, lasts till young adulthood, responds to dietary intervention. This is a good question. Let's see. All right, so yes, it does respond to dietary intervention. It's not rare at all, and you should, well, you can use steroids in the beginning, but it should not be the mainstay of treatment. And it does not, should not last till adulthood because I showed you the GI and the skin are in early childhood, and with time they improve, and the respiratory, whether it's an upper respiratory like allergic rhinitis or asthma, is the manifestation later on. Do you still have more questions, Ms. Kim? No, we still have. At what age does cow's milk protein allergy typically disappear? 6 months, end of the first year, 4 years, 2 months after initial treatment. Let's see. Yes, typically by the end of the first year, most of the infants, they will outgrow their allergies. Some of them, they might last longer, obviously. In the non-breastfed infant, what is the first line of the therapeutic formula to be used? Amino acid, hypoallergenic or partially hydrolyzed, extensively hydrolyzed, or soy-based formula? All right. So the first line is an extensively hydrolyzed formula that should work in most of the infants. If it does not work, then you might consider an amino acid formula. HA is they are good for prevention, not for treatment, and soy-based there is a large percentage of cross-reactivity. I think we have one more question or two more questions. How long therapeutic formula should be used for? Till the age of 1 year, 3 to 6 months, till symptoms disappear, for life. Right? Exactly, till the age of 1 year. That's the most correct answer. Again, because the allergy symptoms they disappear after the age of 1 year in most infants. Do all infants with cosmic protein allergy respond to extensively hydrolyzed formula? True or false? As you all know, if the sentence says all, usually it's wrong. Let's see the answers. Yes, it's false. That's most 90% they respond to extensively hydrolyzed, but not 100%. I think we got all the questions, Ms. Kim. Is that right?
Yes, we have addressed all the questions, and we would like to proceed for any clarifications from the attendees. One of which asking is, how can we differentiate clinically between CMPA and lactose?
Yeah, I think I mentioned some of the differences between both. Cosmic protein allergy usually happens early in life. Lactose problem usually happens in a school age child. The allergy, it might have GI and non-GI like skin or respiratory, but the lactose usually it's only GI manifestation. Usually there is a family history in both of these cases. And in the cosmic protein allergy, you have to give them a diet that's free of cow's milk, while in the lactose problem, you give them lactose free, or you give them drops or tablets of lactose to digest that.
Thank you. Can I diagnose cow milk allergy with GIT symptoms alone?
Of course, yes, you can. Although typically there is a family history of allergy. Typically, there is other respiratory or skin manifestation. But obviously, some of the infants they have negative history, and some of the infants they have only one system involvement. Absolutely.
How to deal with a baby who has CMPA with other food allergy as gluten?
Oh, so children with the other food allergies. You know, currently the mainstay of treatment of allergies is avoided. So they should avoid cow's milk protein or other allergens if they are allergic to gluten or others. The good thing about cow's milk protein allergy and many of the food allergies, they improve with time and they disappear, as I said, in the cow's milk protein allergy at the age of 1 year. With any of these diet restrictions, you should probably seek the advice from a dietitian with pediatric experience, because you don't want to end up having malnutrition secondary to too much restrictive diet.
Thank you. Extensively hydrolyzed formula causes more allergy. Why?
No, extensively hydrolyzed formula does not cause more allergy. It's a treatment for allergy. It does not cause allergy. Maybe the question is probably it causes more loose stools. That's the nature of the formula, because it's a hyper-osmolar formula. But it should not cause more allergy. It might cause more loose stools.
A question from Mr. Abdul Hamid. Please, do you mean the cow's milk, the infant formula, or full cream milk, which is consumed by adults?
No, I mean the cow's milk infant formula.
Breast milk cannot prevent allergy completely, but delays the manifestation of allergy.
It delays and it decreases the risk. Yes. Breastfed babies are at lower risk of having allergies.
Just to clarify, how long therapeutic formula should be used?
Till the age of 1 year.
Can we use goat? Yes. Can you hear me?
Yes, ma'am.
Okay. Can we use goat milk formula for treat CMPA?
No. If you are allergic to one mammalian milk, you are probably allergic to other mammalian milk, whether that's a goat or camels or whatever. Yeah, it's the problem is in the protein. Goat's milk is probably, infant formula based on goat milk can be used for infants with functional GI disorders, but not for infants with cow's milk protein allergy.
When do we expect the symptoms to resolve after shifting to AAF, partially hydrolyzed formula, or extensively hydrolyzed? Does it take weeks or days to expect improvement?
Yeah, it's variable response. Typically within a week or so, you see a good improvement. And to call it a failure, you need 4 weeks.
After the age of 1 year, the infants can drink cow's milk or not?
After the age of 1 year, you can eat anything. He can drink any milk he wants or anything he likes, if he does not have allergy.
Can eczema be controlled by omega-3 rich foods?
I'm not aware of that. Maybe Ms. Dilek can comment on that.
Are using milk ladar with your patient, and which group of patient?
Can you read this question again, please?
Are using milk ladar, I'm not sure if I pronounce it correctly, with your patient, and which group of patient?
Using milk?
Ladar, L-A-D-D-A-R.
What is that? What's ladder? Oh, the milk ladder. Oh, all right. Yeah, the milk ladder is about the reintroduction of dairy proteins, and this is mostly in the literature coming from UK, and they suggest to start by processed protein, if you will, like yogurt or cheese, and you move on up the ladder to the fresh milk. The belief is that this processed protein can be less allergenic than fresh milk, for example. Yes.
Is the loss of albumin and reduced total protein can be the first manifestation of PM allergy?
Is the loss of albumin and
reduced total protein?
Yeah, this is a manifestation of severe allergy. If you have a low albumin, it indicates severe allergy. And in these infants, if they are not being breastfed, I would suggest to use an amino acid form.
Why does soy-based formula also cause CMPA?
Because there is a cross reactivity, 20 to 40% are cross reactive.
Can children have lactose intolerance less than 1 year or only CMPA?
Very unlikely, very unlikely. Very unusual unless it's a post-infectious gastroenteritis or major insult to the intestine.
Can we give mother milk and formula milk together?
Yeah, mixed feeding. Yeah. Why not?
There is any difference between Y-based formula and casein-based formula in terms of allergy prevention?
Your question about whey versus casein protein. Usually, most of the allergy is casein induced, less by the whey protein, although both of them can cause it, but casein is more common. Formulas which is whey dominant formulas are better tolerated and less functional GI disorders.
If the extensively hydrolyzed formula doesn't work, what is next step?
That would be an amino acid formula.
Do we need CA and vitamin D supplementation as a role with EHF?
CA, calcium, you mean. The mother, if she is breastfed, yes, I would suggest to give her calcium and vitamin D. But for the infant, there's no need to give extra vitamin D or calcium because the infant formula is rich of vitamin D and calcium. You might give them the prophylactic dose, which is the 400 units. That's probably indicated, but not as part of allergy management.
Is a low weight in a baby a sign of milk allergy?
Yes, failure to thrive is one of the manifestations of cosmic protein allergy. True.
After how long introduction we start to see improvement in symptoms?
Usually within few days to a week. Again, but to call it a failure, we need probably 4 weeks.
What do you think of skin prick test for allergies?
Oh gosh. Well, it's one of the tests that can be used. It might aid in the diagnosis, but it's not 100% sensitive, not 100% specific. The best test is elimination and reintroduction.
When HA, hypoallergenic formula, is indicated?
HA can be used in the non-breastfed babies for prevention of allergies, i.e. an infant with a sibling or a parent with allergies and the mother is not breastfeeding, then the partially hydrolyzed or HA formula is indicated.
CMPA in exclusive breastfed infant, what is the scenario?
For treatment, I would continue the breastfeeding, encourage the mom to breastfeed, but to avoid any dairy products at all, and yet take some calcium and vitamin D supplement.
Is this formula can be used to limited time? I mean, if child has no allergy after 1 month, we should shift child to routine formula.
No, I would continue till the end of the first supply.
Should mother be under restrictions of dietary if she is breastfeeding?
Yes, ma'am. Yes, dairy, off dairy products.
Can CMPA be diagnosed through serologic tests?
No, no. No, the IgE, yes, but they're not the non-IgE. The anaphylactic reaction one, yes. I'm very pleased to see all these questions. I see we have more than 500 attendees. That's really nice.
Indeed, Dr. Mohammed, we have reached the maximum we anticipated to
That's
host.
all your
today.
efforts, yeah.
and also for a good presentations from your end. There's more questions to address. How to manage FTT caused by CMPA?
How to manage FTT
I
cost?
think that's failure to thrive
Yeah.
caused by CMPA.
Yeah, if somebody is having allergy and failure to thrive, I would go ahead and probably start them straight away on an amino acid form.
Is the watery and yellow color of stool a sign of allergy?
Not typically, no, not typically. But blood in the stool, yes. Mucus in the stool, yes, but not watery or yellow, no.
What do you think about rice protein-based formula in treatment of CMPA?
Standard rice, no. But extensively hydrolyzed rice, yes, it can be used. It's one of the options because rice has been extensively hydrolyzed the same way like cow's milk protein formula has been hydrolyzed or an amino acid form, yes. But not the standard rice, only the hypoallergenic, the extensively hydrolyzed rice, it's possible.
If symptoms after AA started to fade, should we go gradually back to EHF, then pH, then regular, or back to regular diet?
Year, then I will challenge them by giving them a standard formula in a controlled situation. For example, I will bring them to the hospital. I will do a challenge test. The challenge test usually we give them a tiny amount of the formula, usually diluted, and you watch the child after you give them, like for example, 1 ml, and after 10-15 minutes, if there's no symptoms, you give them another ml of probably a more concentrated, and so on and so forth. After 2-3 hours of testing, if they are negative, then you stop, and then the child is not allergic. Either they have allergies or not. I don't think there is a need to go from amino acid to extensively then to partially hydrolyzed.
Is there any biochemical marker for cow milk allergy?
That would be beautiful if we have it. No, I don't think so.
Why most of hydrolyzed formula are LF?
Oh, well, that's a question you might direct it to Ms. Delic from Abbott to answer. My limited understanding is that during the processing, they have to remove all the lactose. If they add any lactose, there is a risk of cross-contamination.
Is the presence of a mucus in stool is normal?
A little bit of a mucus can be okay. More than that is probably a sign of allergy or infection or some other GI disorder.
How can we know a mother is a secretor or not?
Secretor of the HMOs? I don't know the answer to that question. I think clinically you cannot tell unless you test the breast milk, but it was shown that children of mothers who are not secretors of HMO, they are more likely to have infections.
All right, I think we have one last question to address. LNNT, what is its role in GIT and behind?
May I refer this question to Ms. Delic? She might be in a better position to answer this question.
All right.
Is she with us?
Yes, Ms. Delic, is it possible if you can address this question for us?
Hello, Kim. Yeah, hi. Dr. Mekdadi, I'm not very familiar with LNNT science actually. So if you share your knowledge, that's I can comment a little bit about the lactose one, but not LNNT. I'm afraid.
Well, the literature on LNT is the one I'm aware of is limited. It's mostly about 2FL being the most important. Hopefully in the future webinars, we'll have more information about LNT. And you wanted to comment about the lactose
Yeah,
point?
yeah, that one. As far as I'm informed, at least I can say, because these formulas are not only used for allergy but also for GI disorders. They want to. They want to exclude both, well, all the proteins and also the lactose part, so that it can be used for multiple conditions for malabsorption and maldigestion issues. So that was the main reason. This is why the formulas also contain MCT. Like MCT has nothing to do with cow's milk allergy, but it really helps from a maldigestion and like fat malabsorption perspective, if that is the needed from your treatment purposes.
Yeah, MCT, it helps in the absorption because the medium chain triglycerides are directly absorbed and improve the weight gain of the child. Yes.
Thank you for that. We just have a follow-up question. What's the side effect of feeding 6 months baby with cow's milk? In addition, would it affect his health in future?
I think the question means a child being fed regular cow's milk, the fresh cow's milk, not the infant form. Regular cow's milk or fresh cow's milk should not be given to infants below the age of 1 year for multiple reasons. One of them is the allergy, others are the renal and the kidney complications, the low iron content, and many other problems. So it should not be given. And again, regular cow's milk does not have any of the human milk oligosaccharides. It has been added to some of the infant formula only.
Thank you so much, Dr. Muhammad. It was really a great pleasure to work with you and to provide this very interesting, informative topic. Aside from those questions, we have gathered good feedback from the attendees. It was a very interesting lecture. It was precise. It was a lot of information on it. It was a great topic, a great presentation. It was really great to have you with us. Thank you. And on behalf of TEDKIP, we really thank you for taking this time on this late evening.
Thank you, Ms. Kim from TEDKIP for giving me the opportunity to virtually be with more than 500 attendees, which is one of the largest webinars I've been invited to. And thanks for Ms. Tillich and Abbott for sponsoring tonight's event. I enjoyed the presentation and the questions as well, and I will be happy to communicate with the attendees after this webinar if there is anything I can help with.
Of course, we will always look forward to collaborate with you in the future, and I will be always in touch with you for any further collaborations that we can do.
Thank you very much.
Once again, everyone, panelists, Dr. Muhammad, Ms. Dilek, on behalf of the KIF Health Treatment Undertaking Services, we would like to thank you and to acknowledge the presence of Abbott Laboratories SA and sponsoring this event. It was really wonderful to have the maximum attendees we can host for tonight. It's really wonderful to see all these people, dietitians, pediatricians, GPs, all the specialists that have gathered for tonight who took time to be with us. Once again, we would like to kindly remind everyone to please continue to follow the KIF Health Treatment Undertaking Services on its all social media platform, Facebook, Instagram, Twitter, YouTube account, for you to be able to receive the recent announcement of our upcoming activities, future activities. And at the same time, you can also go back to our social media account to view our session for today, and any pre-recorded session will be uploaded on our YouTube account. You can always review it back. Once again, you will be receiving an email from us, 2 links that will be the post test and the evaluation. After filling this both 2 links, we will be processing your certificate with CME accreditation from DOH. We are also pleased to announce that for those KSA attendees, Abbott were able to gather an accreditation from your ministry in KSA. We are just following up on with KSA team to provide the certificate with KSA accreditation. So once again, thank you so much, everyone, for your time. Please keep in touch, and you will be able to reach us on our email, social media, and our contact details in our on our signature. If you have any further questions, any clarifications, you can direct it to us or any medical representative from Abbott, and we'll be happy to assist anything further. Once again, thank you, Dr. McDaddy. Thank you, Ms. Delic. And for everyone who attended for tonight, it was really a pleasure to host you for this wonderful session, wonderful workshop. And we hope to host you again in the near future. In the meantime, stay safe, everyone.
Thank you very much and have a good evening.
To you too, Dr. Muhammad. I'll be in touch soon. Thank you so much. Thank you, Ms. Dilek.
Thank you very much. Have a nice evening, everyone.
Stay safe, everyone.